All right. So, welcome to this lecture. We're quickly going to finish two slides that we were supposed to do in the lecture about the physiology of the lungs, but we were unable to due to time constraints. So, I hope some of you at least remember something about partial pressure from the last lecture. And what we know is that if atmospheric pressure at sea level, so talking about the Netherlands, for example, so the largest parts of Europe and the east and west coast of the United States, there you're at about sea level. Then, if atmospheric pressure is 760 millimeters mercury, then the oxygen pressure is about 150, so about 21%. Then, let's see. We have two other situations. So you can imagine that this oxygen pressure and that this atmospheric pressure might increase or decrease when you go up a mountain or if you go under the water into the sea. So perhaps a little question to you guys. Do you think the partial pressure of oxygen goes up or down when you climb higher in the mountains? Some people say up, some people say down. So the truth is that it goes down. So at about 33,000 feet, the partial pressure is about 40 millimeters mercury. And 40 millimeters mercury means that instead of getting oxygen into your body will actually lose oxygen because the pressure is too low to maintain itself. So if you're at if you're at pretty high levels of elevation, so at pretty high heights, then pressure will go down, and that has some side effects. So we'll talk about mountain sickness on the next slide. And then, of course, on the other hand, we have sea level, which is where it very rapidly goes down. So you can see that if you go up by 33,000 feet, that it decreases by about four times. So it's about a quarter of 150. Whereas if we go 100 feet under the water, then pressure of oxygen would be 600 if oxygen existed there, because that's a trick question. But you can imagine that if the partial pressure, if the atmospheric pressure is about 760 here, it's about 3,000 when you go 30 meters or 100 feet below sea level, so into the ocean. And that's pretty dangerous, which is why, for example, if you become a physician that works in a pretty hot country with accessible options of deep sea diving, that you will sometimes meet emergency patients like these in the emergency department. They're often unexperienced scuba divers or deep sea divers that will then for example, lose pressure in their oxygen containers, or they will have problems with the neurological problems because of increased pressures. There's an increased pressure pushing onto your body as well. But of course, it's mean of me to say that the oxygen partial pressure is 600 because there is no oxygen in the ocean. If you were to be at land, though, and not in the ocean, then there would be a partial pressure, but not 600. For example, if you would go 33,000 feet into the ground, which is unlikely, but then you would see a partial pressure of oxygen of 600 millimeters mercury. Let's see. Someone asks, isn't there oxygen in the ocean, though? There is to some extent, but there's not as much oxygen production in the ocean compared to the atmosphere. That's true. And that plants like algae can respire oxygen because they metabolize carbon dioxide. And now, which might be interesting, which is mountain sickness or acute mountain sickness. So as you increase the height at which you are, you will get several consequences. So, for example, at 6,000 feet, you might experience dizziness or slight irritation. People can get annoyed easily. That's literally what irritation means in this case. And if you double that height, so 12,000 feet, people can present with drowsiness and muscle fatigue. And the same is for 18,000. Although in 18,000, people can also already start getting seizures. And that's pretty dangerous, right? You can imagine that if you go back, 33,000 feet is 40 millimeters. So this is roughly half of it. And about at half of that, you start having seizures. And then here we have 23,000 feet, which is without acclimatization. I have to mention, I'll talk about what that is later. This might result in comatose state or even death in some cases. And then someone asks, is that why inexperienced people die on Mount Everest? That's exactly the reason. So what you can do to prevent mountain sickness is you take a medication called acetazolamide. And acetazolamide is something called a carbon anhydrase inhibitor. And what it does is that it causes your kidneys to be unable to form a certain acid called carbonic acid, and therefore you will have more CO2 in your body. And more CO2 in your body means you'll start to respire more. Because the main reason why these patients with acute mountain sickness present with these symptoms or these consequences is because they are unable to adapt to necessary increases in ventilation. And then also someone asks, so I live at 7,000 feet. Does your body adapt to the change in height? It does. It is actually known that because, acclimatization is the adaptation to higher heights or higher elevations. And these are all symptoms without acclimatization. So imagine if I take you now and I put you at 23,000 feet, then you'll likely have seizures, end up in coma, and then die. That's what happens. On the other hand, if you get acclimatized, so you do it in baby steps and take several days rest after each step, and you make sure that you keep oxygenated and keep up with this rhythm, then you can do fine. But this is usually for very experienced mountain climbers. But it is true that for people who are born at high elevations, for example at 7,000 feet, these people will be naturally better acclimatized. And someone who is born at sea level and trains himself to perform better at such high elevations will never reach the same level of acclimatization as someone who is born in the mountains. Let's see. All right. Are there any further? Oh, right. And I also have to mention that another reason why patients can get seizures is because of brain swelling. And brain swelling can be treated with something called dexamethasone. And dexamethasone injections through IV will alleviate symptoms of seizures in these patients when they enter the ER. Let's see. All right, now we go on to hormones, the physiology of hormones. That's what we're actually for this lecture. So there's, first of all, a lot of different types of hormones, and the ones that I have marked in blue are the ones that we're going to talk about today, because in Seattle Race Hospital, we do not discuss the sex hormones because they go against the terms of service. On the other hand, let's see, amino acid hormones, peptide hormones, and steroids we do talk about because these are hormones that are natural and that have some very important diseases related to them. And over here you can see a list of organs that produce hormones. Let's see, for example, over here we have the thyroid with 4 parathyroid glands. We will talk about those, the thyroid and parathyroid. But perhaps it's interesting to know that the heart can also produce hormones. And not a lot of people know that. There's not a lot of hormones that the heart can secrete. There's primarily one that we will talk about, but it's pretty important, that hormone. But if we really look at endocrine organs, we often talk about things like the thyroid, like the hypothalamus, pineal gland, and pituitary gland, and the intestines and the pancreas and the adrenal glands. So those are the most prominent endocrine organs. All right. Then we have the CNS hormones. So the hormones secreted by the hypothalamus and the pituitary gland. And you have to know that, like over here, you see the hypothalamus, which is a part of the brain located below the thalamus. Makes sense. Let's see. Someone asked if we can pause for 5 minutes. That's fine, I think. On the other hand, we will be recording this, so we don't have. Let's see. We don't have to have a break necessarily. So quickly back to chemical messengers. There's 3 main types: steroids, peptides, and amino acids. And we will be discussing all of them except for the sex hormones. And over here, you see a list of dominant organs in the endocrine system. So these are the hormones related to the central nervous system, and they do not come from the thyroid; they come from the thalamus. So over here, you see the from the hypothalamus. Sorry, over here you see the hypothalamus. Over here you see the thalamus, and that's where something called prehormones often come from. And these hormones are not important to know for now. But what is important to know is that these hormones activate parts of the pituitary gland. And the anterior pituitary gland is more important than the posterior one, or at least there are more hormones secreted by the anterior pituitary gland. There are some sex organs or some sex hormones that are secreted by the anterior pituitary gland, so I've deleted those. But there are certain hormones that are important and are secreted. First of all, there's growth hormone, which is a hormone that is responsible for the growth of, for example, bones and muscles, but it's really important for the growth of almost any organ because it's also something known as a growth factor. And then there's ACTH, and ACTH is a hormone secreted by the anterior pituitary gland that stimulates the adrenal cortex or the adrenal glands to secrete hormones. The anterior pituitary gland also secretes TSH, which stands for thyroid stimulating hormone, and it stimulates secretion of thyroid hormones by the thyroid gland. And that's the anterior pituitary gland. And then there's the posterior pituitary gland, which predominantly produces vasopressin, also known as ADH or anti-diuretic hormone. And that hormone is produced by the kidneys, and vasopressin is used to reabsorb water back into the body. And then over here at the left, you can see, first of all, at the top, you see kind of the nervous stimulation of the pituitary gland. Over here, you see something called the supraoptic nucleus, which is a group of neurons, a group of cells that can actively stimulate the posterior pituitary gland. And similarly, the anterior pituitary gland, which is not shown here for some reason. And next to that, the blood supply is also pretty important because, as you can see, the pituitary artery goes over here. It goes into the posterior gland, but that's mostly to supply them with oxygen, because as you can see, as soon as it hits the anterior pituitary gland, most of this is deoxygenated. And the reason why it's relatively simple is because the hormones secreted by the anterior pituitary gland often need to be transported through the blood. And there's a lot of hormones that they produce, so you need a lot of blood supply. And it doesn't necessarily have to be oxygenated because you just need to move the hormones. Let's see. Then over here we have the thyroid. These are a lot of images, and I don't expect you to remember all of these. But what's important is the following. Over here you see the thyroid gland, which is right on top of the trachea and right below the larynx. So if you would feel it for yourself, it's pretty close and it's right around your trachea. And not a lot of people realize that it's there, but it is. And it consists of, as you can see, follicles, which are kind of sacs where hormones are stored. And outside of these, you can find capillaries and connective tissue. And that's what this consists of. Let's see. And the reason why this is so important is because of the following. You can see over here on the right, this is a cell. This is something called a cuboidal epithelial cell. And these are the cells that separate these follicles from the connective tissue. And what happens is that, as you can see, iodine flows into the cell. Iodine, the what do you call it? The ion, which is moved in, and then at the inside of the follicle, you see that it's formed. So let's see, iodine comes in from the bloodstream, it gets in here, and then it forms hormones, including, for example, T4 and T3. And these hormones are very important, and we will come to that later. Oh, in the next slide, actually, about Graves' disease and Hashimoto's disease. And what then happens is that as soon as they are needed or have to be released, they can be secreted over here into the capillaries again and then be transported. And the reason why T3 and T4 are important is and especially T4, it's because these hormones regulate the largest parts of metabolism. So as you can see, the following 5 are the most important consequences of T4 and T3. And it's predominantly metabolism and growth, but also development of other systems. And it helps with the cardiovascular system to increase cardiac output, for example. Now here's a clinical case or clinical study again. So we have Graves' disease and Hashimoto's disease. On the right we have Graves, and on the left is Hashimoto's disease. Because there are some diseases where, let's see, sometimes your thyroid works too much or too heavy, and sometimes it doesn't work at all. And patients with hyperthyroidism usually present, and both are autoimmune diseases, by the way. Patients with hyperthyroidism present with a lot of weight loss. And why do you guys, can you guys come up with a reason why patients with Graves' disease or hyperthyroidism have a lot of weight loss? Dr. Mangas has low metabolic function. Sarah says because of the metabolic hormone. All right, I need something more. Yeah, so let's see. Claude says there's less T3 and T4. Is that true? If the thyroid is hyperactive, will there be less of this? No. Instead, there will be more of this, right? There will be more. And so if there's more thyroid hormone, more T4, hyperthyroidism, that will lead to increased metabolism and therefore loss of weight. Yeah. More metabolic output. Correct. And hypothyroidism is, of course, the other side. So it causes a decrease in metabolism and therefore weight gain. Now, you have the parathyroid gland. And the parathyroid gland are 4 small glands that are on top of the thyroid gland. And they have nothing to do with iodine, but everything with calcium. And what they do is that in response to low calcium levels in the blood, the parathyroid gland starts secreting parathyroid hormone. And what parathyroid hormone does is that it activates, for example, vitamin D3, and it activates all different kinds of processes within the body that stimulate the release of calcium into the blood. For example, reabsorption through your intestines, a reabsorption by your kidneys, because some of your calcium is always lost through your kidneys, through excretion, and a calcium release through the bones. And specifically in the kidneys, it might be interesting to know that if you can see that calcium can be either transported through the cell, so transcellularly, or next to the cell together with water. So when water flows out, it always grabs a bit of calcium with it, which is called paracellularly, and it's about 50-50. So about 50% of calcium is reabsorbed this way, and when parathyroid hormone becomes active, because there's too less calcium on this side, for example, let me have a pen. if there's low calcium on this side, plus plus, some people say 2 plus is also fine, at least in medicine it is. What happens is it results in this part, which means that more calcium will go that way, and this is stimulated by parathyroid hormone, this one. And let's see. Then we go to the kidneys and the adrenal glands. So first, the kidneys. There's something called the RAS system. I think we might have discussed it during an earlier lecture. There we go, the RAS system. And the RAS system stands for renin over here, angiotensin. Oh, it's an angiotensinogen. Hold on. Let me erase this. So there's renin, there's angiotensin, and specifically angiotensin 2, and aldosterone. And what these together do is that they help increase blood pressure. So what happens is that as soon as the kidneys notice that there's not a high blood pressure, which they do by measuring sodium levels. So if halfway down the kidney, so halfway down excretion, the kidney notices that there is too little sodium present, then it will say, all right, I'm going to start secreting renin. And renin acts on something called angiotensinogen, which is produced by the liver. And when renin does that, it gets converted like this into angiotensin 1. And then let's see, renin in itself has an effect of increasing blood pressure by constricting blood vessels. But what it does is that it activates angiotensinogen and forms angiotensin 1. And angiotensin 1 also has this potential. And then angiotensin 1 moves to the lungs, oddly enough, and to the blood vessels of the lung. And it not just in the lungs, also in the kidneys themselves. But there's an enzyme here called ACE. Perhaps you guys are familiar with medications called ACE inhibitors. Those are antihypertensives. And what they do is that they inhibit the function of this hormone, or of this enzyme. Sorry. And what happens then is that you get less angiotensin 2 and therefore less increased blood pressure. And so if angiotensin 1 gets converted into angiotensin 2, angiotensin 2 has many effects on the body. And for example, what it does is, first of all, that it increases constriction, and it also increases sodium retention. I'm just going to put it like this, retention. And retention means that it stays within the body instead of getting excreted. And what angiotensin does is that it goes to the adrenal glands, which we will talk about soon. You can see it over here, the adrenal gland. And it will stimulate the secretion of aldosterone. And aldosterone helps in actually increasing blood pressure by having vasoconstrictive effects on the arteries as well. And that, together with retention of sodium, causes an increase in blood pressure. And that's what the RAS system is for. I think that we will discuss the kidneys during a later lecture. That's when I will deeply discuss the RAS system, because it's a very important system to be familiar with, because cancers of the kidney or cancers of your adrenal glands can cause disturbances in the RAS system. And there are diseases like hyperaldosteronism that can actually cause increased blood pressure for no apparent reason. Now over here we have the adrenal gland, which are glands that are right on top of the kidneys. As you can see at the image of the kidney here, this is an adrenal gland, for example. And just like you have 2 kidneys, you have 2 adrenal glands. And the adrenal gland has 2 main layers. It has a cortex, which is about 80%, and it has a medulla, which is about 20% of the adrenal gland. And they each secrete different hormones. So the cortex and the medulla are, the cortex is stimulated by CTH, which was again that hormone that was released by the anterior pituitary gland. And what it does over here is that it stimulates the following zones. So this one to this one over here. So the gray and the blue one and the orange one. Let me draw it further like this. And they stimulate the secretion of the following hormones. For example, aldosterone and glucocorticoids, which are important in stress reactions, but also in dampening immune reactions. And then there's, of course, the androgens and estrogens, but we are not going to discuss those today. And about 80% of the adrenal glands secrete this. And then there's 20% which secretes hormones called catecholamines. And catecholamines are hormones such as epinephrine, norepinephrine, and dopamine. And this is often as a result of parasympathetic stimulation instead of hormonal stimulation or sympathetic stimulation. Okay, then there's the pancreas. So the pancreas looks like this. This is the pancreas. And this is, I think, a part of the, as you can see on this image perhaps. So if this is the pancreas, then this is part of the small intestines. So this over here, if you ever get it on a board exam, this picture, this are the intestines. Oh god, tins. There we go. Intestines. And then there's, let's see, there are three main types of cells in the pancreas. So there's, of course, these are kind of sacs where hormones can be stored. But this is important. These are the islands of Langerhans. I think he was a German scientist. And there are three different types of cells found in the islet of Langerhans, which is, first of all, the alpha cells that produce glucagon. There's the beta cells that secrete insulin. And there's the delta cells that secrete somatostatin. And what glucagon does is glucagon, I hope I'm pronouncing that correctly. So glucagon, I will type them. Hold on. Glucagon, there's insulin, and there's somatostatin. And they're all found in the islets of Langerhans. All right, typed. Glucagon, of course, the main question is, what does it do? Glucagon stimulates the release of glucose by your liver, first of all. And secondly, by the, how do you call them? Yeah, adipose tissue. So let's see, adipose tissue, which is fatty tissue. And Dr. Polo made me mention that you have to know that it's not just lipids in your blood, but it's actual fatty tissue. And thirdly, it's muscle. And what glucagon does is that it causes release of glucose from these organs. And what insulin does is insulin works as a like a gatekeeper of glucose entering cells. Because if you look at a cell, and this is a cell membrane, and this will be a portal for glucose. And this is the inside, and this is the outside. And so these portals can be closed, or generally are closed. Let's see, this portal. So if a glucose molecule is here, then normally speaking, it can't enter. But what does insulin do? Insulin, this one, for example. Let's see, where's insulin? No, that's not insulin. Yeah, it is insulin, this one. What it does is that it moves to a receptor that's close to it. So for example, here, it will bind to it. This little ball is insulin. It binds to a receptor, and then the gates will open. And then glucose can flow in. Let's see. And of course, next to, let's see, so a common disease of the pancreas is diabetes mellitus. So there's two types, type 1 and type 2. And what happens in type 1 is that it's an autoimmune disease. So your immune system will actively attack the beta cells. So these gray cells over here, dead. They're all dead. And they don't produce insulin anymore. So your body still needs it, but because there's no signal that says glucose can enter the cells, they won't. And secondly, there's type 2 diabetes, which is that your pancreas secretes too much insulin, and that is often because you're resistant to insulin, as in these receptors. So insulin can bind to them, but you won't be as sensitive to insulin binding to these receptors. And therefore, glucose can still sometimes enter the cell, of course, because you don't actually die, but at a decreased rate. And now again, to specify diabetes mellitus, and especially the two different types, you have to know the differences between these. Whether you're a surgical or non-surgical resident, it's important. First of all, diabetes type 1, because it's an autoimmune disease, and because it's partly genetic, the age of onset is usually young, so below 30. Whereas in type 2, patients are often older, because type 2 is often associated with being old, so elderly patients, or with being overweight. And that brings us to the second one. Patients of type 2 often are overweight and therefore insensitive to insulin, whereas people with type 1 have enough insulin, or well, they have enough insulin sensitivity, but not enough insulin. And therefore they will not be overweight, but rather lean or slim. Let's see, the duration of symptoms. So after the disease has established, a patient of type 1 diabetes will often present within weeks or days, whereas the symptom duration for type 2 is months to years. Next to that, what you see is that ethnicities like people from Northern Europe, particularly Scandinavia, particularly those people are in trouble. They have genetic predisposition to genetic predisposition to diabetes type 1, and we will talk about that later here in heredity. Whereas type 2 is often in Asian, African, Polynesian, and Native American people. And why is that? Well, it has partly to do with globalization. So that Europe, of course, has access to a lot of food, whereas these regions originally didn't, or at least not compared to food production in Europe and North America. And what happens is that these groups got westernized. And as a result of that, their diseases or their eating patterns are relatively bad or relatively European. And in Europe, you're simply more likely to get diabetes. And so these ethnicities have skyrocketed in terms of diabetes type 2. And what's perhaps interesting to know in that respect is that if you go to these nations and you see someone with diabetes type 2 diabetes is a disease of the affluent, of the rich there. Whereas in North America and Europe, if you have type 2 diabetes, you're more likely to be poor because of poor dietary habits. Then there's seasonal onset, which I will not dive too much into, but type 1 diabetes is associated with heavier onset during certain times of the year, and that depends per patient. Then there's heredity, so whether there are genetic links to type 1 diabetes or type 2. So there's something called HLA, which has to do with your immune system. And we know that because type 1 is, as we said, an autoimmune disease, that there are certain genes that are found in over 90% of patients with type 1 diabetes. And therefore, it is likely to be somewhat hereditary, and therefore it's more commonly in Northern Europeans because they often have these genes. Whereas there are no links to your immune system in type 2 diabetes, and genetics play only a minor role. And pathogenesis, so the origin, again, type 1 is an autoimmune disease and type 2 is not. Then we have ketonuria, which is the presence of ketones in your urine. And the presence of ketones in your urine often means that your body is breaking down a lot of fat, because ketones are a metabolic waste product of fat metabolism, of fatty acid metabolism. And you more often see this in patients with type 1 compared to type 2 diabetes. And then clinically speaking, type 1 is full insulin deficiency, whereas in type 2, the patients sometimes have partial insulin deficiency, but it's mostly based on insulin resistance. And if a patient presents with diabetic ketoacidosis, it's most likely to be type 1. And ketoacidosis means that there's a lot of ketones in your blood, which cause your blood to become more acidic, and therefore ketoacidosis. And what happens in type 1 patients is that they always need insulin. Whereas in patients with type 2 diabetes, they only need insulin where their beta cells are failing, which happens in a minor fraction of patients. Then there's the liver. So the liver has some hormonal functions and some other functions. So first of all, there is the function of the liver that it removes toxins or byproducts, and it helps metabolize medication, sometimes intentionally, because sometimes you have a medication of which the metabolites of that medication are actually the medications that do the work, and sometimes they do it in order to break down and excrete it. And then there is that metabolism. A lot and a huge part of metabolism occurs in the liver, and therefore, if you ever decide on becoming a hepatologist, so a liver physician, or a gastroenterologist, a person who specializes in the gastrointestinal tract, you will most likely have to deal with metabolic disease or liver disease. Then there is that it helps your body with infection, and it does so by, first of all, it produces something called CRP. And CRP is something that we use in order to diagnose infection. So the liver produces CRP, and if I ever ask you this during a shift, the liver produces CRP. Next to that, what it also does is that it can release certain cytokines. Oh god, cytokines and complement factors are produced by the liver. Next to that, produces blood clotting, also interesting. So there's a mnemonic for this. So we haven't talked about hematology and blood clotting yet, but eventually you will. And you have to know that the liver uses vitamin K for this. So vitamin K. And the liver produces all factors. And you have to know that the factors that require vitamin K are 2, 7, 9, and 10. These factors, because there's about, I think, 13 different factors. And a mnemonic for this is 2 plus 7 is 9, not 10. That's the way I remember this. So the clotting factors produced with help from vitamin K are 2, 7, 9, and 10. Next to that, it is also involved in absorption of a lot of vitamins and produces something called bile, which it stores in this small organ that's usually below it, over here, which is the biliary cyst or the gallbladder. And then, let's see, it produces a lot of proteins. Does someone know a blood protein, for example, a protein found in the blood? Really? Anyone? A really important protein? Not CRP. Yes, that's true. So it's CRP. That food. I mean a different protein. It starts with an A and then L. So does anyone perhaps know? L something? Yeah, that's very close. It starts with AL. I think someone knows. Which protein do you think it is? Albumin. Very good. Albumin. That's an important protein in your blood, and it's produced by the liver. And then we have that it prevents shortages of nutrients because it can produce glucose, for example. Those are some very important functions of the liver. We will, this is just a minor introduction to the liver, but we will later have a lecture completely dedicated to the liver and liver disease, because the liver is a really important organ. Then there's adipose tissue. So fatty tissue is able to also secrete hormones, particularly estrogen over here. And secondly, what also happens is that obesity is often linked to insulin resistance over here. And that's why obesity, as we go next, is very important in not just diseases, but it's also very important to prevent obesity and overweight, because it has a lot of different side effects. And this is an image which mainly is related to obesity in children. But almost all, or at least as far as I can see, all different body systems have their negative side effects of obesity. Particularly if you go to endocrine functions, because that's what we're busy with today, type 2 diabetes, but also pubertal disease. And then lastly, we have the heart. So you guys remember that I talked about the RAS system, right? And the second A in RAS stood for aldosterone over here. And now what's so special about aldosterone? Aldosterone is the exact opposite of a hormone called ANP, atrial, atrial, A-T-R-I-A-L, and then natriuretic. So N-A-T-R-I-E-T-I-C, and then peptide, about this, right? ANP. And natriuretic means excretion of Na, or sodium, because in Latin, sodium is called natrium, and also in most other languages. For some reason, English says sodium. Same goes with plus, which is in English potassium, but in Latin it's kalium. Kalium in Latin. All right. And it has the exact opposite effect of aldosterone. So aldosterone helps to increase blood pressure, whereas ANP helps to decrease blood pressure. And it's secreted by the heart. That's weird, right? So how does that work? So what happens is that there's in your heart there's something called an SA node, and you guys know that the SA node is responsible for sending signals to the rest of your cardiac conductive system in order to actually have your heart contract. So what happens is that if this SA node is stretched too much, or if the atrium itself is stretched too much, as you can see here, and it can be stretched, for example, by high blood volume, or by, it's predominantly high blood volume. What happens is that your body will start to excrete more, how do you call it again? Water. So it wow. So it starts to excrete more water because of ANP, because of this hormone. Let's see. Now I'm gonna try and answer some questions that you guys sent in. So I'm gonna scroll back, because I think people had some questions earlier as well. Let's see. Someone asks, I don't know why I'm learning this when I'm going surgical. What are the chances an endocrine patient comes in? Good question. So let's see. Endocrine patients are rare, and pancreas transplantation is also rare. For example, liver transplantation is also relatively rare. Thyroid transplantation is not rare. Kidney transplantation is relatively frequent. The kidneys were the first organ transplant ever, I think, of a dog, and it's relatively easy compared to the liver, for example, to acquire a kidney. And now you wonder, why do you need to learn this? Well, the thing is that in spite of being a surgical resident, for example, imagine you later on become an attending and you have to work in the ER because there are no other attendings that can work in the ER. You have to be familiar with some basic concepts. So it's nice that you like surgery. I have no problem with that. Like back in 2017, I did some surgical things within RGH, but still it's important to even know some non-surgical things, and as well as for non-surgical residents to know some surgical things, right? Because if you completely specialize into only one topic, then I would say you are a relatively shallow attending. Let's see, other questions. Let's see, someone says insulin is like a check balance to your glucose. Yeah, to some extent. Then I'm looking, I don't see. I have a question. What's homeostasis? Someone asks. Homeostasis is the balance. I think. Wait, is she in the VC or not? I don't think she is, right? But homeostasis is basically an equilibrium. So you can imagine it as this is, for example, now this is a balance. And what you see is that there's factors that can cause something to go upwards, and there's factors that can cause something to go downwards. This is, for example, heart rate. And homeostasis is the way in which the body organizes itself in order to maintain this balance. Because the normal heart range is 60 to 100, but your heart rate prefers to be around 75. 75, it thinks it's a nice number. And what happens is that sometimes there's factors that increase your heart rate. For example, getting stressed at a shift or yelling at a resident because he didn't know a minor thing. There's bodily mechanisms that help me decrease my heart rate. And disease is basically a disturbance of this homeostasis. A disease is typically too much of something or too little of something. So a disturbance of homeostasis. That's what homeostasis is. Relatively important also for hormones. Let's see. Then there's, is there another question? Can you go over the chemical messengers in CNS one more time? Sure, I can. Let's see. We'll go back very quickly. Chemical messengers. So there are three types of hormones, three main types of hormones. There are steroids, there are the peptides, and there are the amines, or the amino acids derived hormones. And the reason why they are categorized like this is because of their structures. So the thyroid hormones over here are amine hormones produced by, for example, your adrenal glands over here are mostly steroids. And then there's peptides, which are produced by your pancreas, for example. This is your pancreas over here. Peptides. P-E-P-T-I-D-E-S. Peptides. Yeah, peptides. So peptides is a small protein. Small protein. So if you imagine this is a protein, this is a peptide, for example. So this is a protein like this. Yeah, similar to peptide chains. So a protein is the same as a polypeptide. All right, and then quickly to the CNS hormones again. You have here the hypothalamus, and the hypothalamus, as you can see it as well, over here, this entire part over here is the hypothalamus. And the hypothalamus is a collection of nervous cells that stimulates the secretion of pre-hormones. So let me post that in the chat, actually, pre-hormones. And what do these pre-hormones do? They stimulate secretion of hormones. Yeah. So what happens is that So the hypothalamus secretes pre-hormones, and then the anterior pituitary gland and the posterior pituitary gland secrete hormones. Pre-hormones, yes. So they are technically hormones, but they initiate secretion of another hormone. You can imagine that technically how it goes is this: there's a pre-hormone, PPH, which stimulates secretion of a pre-hormone, PH, which then stimulates a regular hormone, secrete, like to secrete. All right, and so this one stimulates. So it's a plus. This one's also a plus, and this hormone itself will inhibit this one. And why does it do that? For example, we have a lot of this, and because then this is a plus, we get a lot of this. This is a plus, then we get a lot of this. And because we already have a lot of this, if this inhibits this, it will cause this one to go back down again and become normal, also known as homeostasis. So the hypothalamus are the pre-hormones, PPH. These are the pre-hormones, the PH, and these for the cortical hormones, the thyroid hormones, and ADH, for example, and are hormones. And is there a specific function of naming them like this? Well, according to physiologists, it's more easily to organize it in this way. Sorry. All right. Were those all questions? No more questions? All right. If that was it, then this concludes the lecture about the hormones. We can later, perhaps after the shift, discuss a patient case related to this for you guys to digest. Again, just a reminder, regardless of whether you're a surgical or non-surgical resident, you have to be familiar with concepts of both non-surgical and surgical specialties. And the reason why is because you have to be able to help people. You don't have to know two specifics, but it would be useful to know something about everything. And that basically concludes the lecture. Let's see. All right, remove.